the new device. This is the first time I had seen something. This is not on this image, but you can see this patient came in, acute MI, heart failure, is on ECMO, but also has an Impella. And this is the typical type of Impella we see that has the pigtail catheter in the left ventricle, or this pigtail tip in the left ventricle. And of course, like this portion should span the aortic valve. And as these are connected externally, the monitoring computer kind of knows based on the pressure differential if it's in the right place. But then I'm curious if you guys have seen this one. Then a few days later, all of a sudden, you see this device, which is now coming in via a right axillary / subclavian arterial approach. And it looks kind of like an Impella, except there's no longer a tip on here. And yes, first I was curious if you've seen this, Seth.
Yeah, first time I saw it, I had a call too. We've been using it
exactly right.
Past 3 or 4 months, I think.
Yeah, this was the first one I had seen, but this is the Impella 5.5, and I guess it can produce a higher throughput, and there is no tip on this. So if and when you see this, since it's a new device, and it sounds like it's multiple places, that you don't have to worry about the fact that there is no tip on this, that this is how it is supposed to look. So that was just a quick little alert for everyone.
Can you go back to your first study?
Yeah.
What is that? Is that just an ECMO catheter? What is that?
Yeah. Here? Yeah.
That's just one of your ECMOs? That's a little different than ours. Okay.
Correct. Yeah.
Yeah, we have those too, but that seems a little higher than I've seen ours. Ours are usually like much lower down.
Yeah, they're trying to get both they're trying to get both the SVC and the IVC with this.
Okay.
So it's kind of traversing the right atrium here, but yeah, new Impella. All right. This one is just crazy. So this is a patient with COVID, and this is their presentation. You know, nothing remarkable really about this. Looks like lower lung symmetric opacities. And on their initial CT they had in the hospital, you can see findings of organizing pneumonia, symmetric peripheral ground glass opacities. It's kind of cool because some of this looks like organizing pneumonia we occasionally see with mixed with NSIP and connective tissue disease. But then over the course of a few days, the patient starts to develop these fairly symmetric upper lobe areas of consolidation. And I'll just go fast forward a couple of days later. There were like 4 or 5 radiographs over the course of 2 days. And this is what their lungs look like. And this is only a few days after that prior CT. And they got another CT that I'll show you in the interim. But in the meantime, this patient had a significant drop in their hematocrit, and they had some blood from their endotracheal tube. And it's just to me, it's just so shocking how there's like almost a straight line here with this dense consolidation in both upper lobes. And you'll see on the CT, it's exceedingly high attenuation on this non-contrast CT. And when they bronch the patient, all they found was blood. And so this was hemorrhage in the setting of ARDS from COVID. And I don't know, it's just such a bizarre look. And the patient's still in the hospital and not doing well. But this was just so strange. I had never seen hemorrhage, look like this in anyone. I'm curious.
Yeah, we know there's a lot of coagulopathy with COVID. I wonder if this person consumed all of her platelets or something like that, and then was susceptible to bleeding for that reason.
Yeah, but why just the upper lobes? I mean, that's
right.
That's weird. I can't explain that.
Yeah, you can. I mean, it's like you can draw a straight line. I mean, here they were.
Did her H&H drop with these?
Oh, yeah. Yeah.
There was a precipitous drop with that.
Yes.
I've never even
seen a substantial drop.
What did her other lung, the less dense lung, did it look like hemorrhage, like those fluffy acinar or lobular nodules? Did it look like that, or did?
No, it kind of looks down here like just evolving acute lung injury and organizing DAD. You've got some traction. I'm sure there's some consolidation here. I just can't. So there's probably hemorrhage in the lower lobes as well, but I can't explain, why there's basically like this. It's like above the equator, it's all just super dense and socked in.
Did they bronch her?
And yeah, oh yeah, it was all blood.
That's weird.
No infection. Yeah, it's just totally bizarre. I can't.
You know,
I don't know if they're.
Travis, the only time I've seen sort of lobar consolidation from hemorrhage is when it's like bleeding from a specific site, not the typical alveolar hemorrhage where you get the more central lobular acinar type stuff. But to have both lobes, like, that's weird. All right.
Yeah,
well,
that's why I wanted to show this, just because it's a. Yeah. All right. Well.
Yeah, we can add that to our COVID signs and write a paper.
I know this is. Yeah. I don't know what you call this, but we'll have
The
to think about it.
sales sign. Oh, it probably is already a sales sign.
All right, and then I'll show this one really quick here. This is. I think this is a very interesting case. So this is a man who I think is he's in his 60s, yeah. And he's got multiple comorbidities. He's had a prior renal transplant several years ago, but you can see there's volume loss and mediastinal rotation on the left. And this, it turns out, is due to a left upper lobectomy that was done in 2007. So this does become relevant down the road, because over the last couple of years, he's presented with worsening dyspnea, and one thing led to another at the outside hospital, and they did a right heart cath, and they found that he had pulmonary hypertension. And so this was a non-contrast CT, kind of part of a pulmonary hypertension workup. And you can see his right lung looks pretty normal. His left lung, though, on the other hand, as you can see, there's what looks like some septal thickening, probably a little bit of chronicity to it, some tortuous little corkscrew vessels along the pleura. And of course, the next thing I went to, even on this non-contrast study, was instantly looking at the pulmonary veins. And it looks like there's a suture along the left inferior pulmonary vein as well. And you can see his suture from his left upper lobectomy. So they, to complete his workup, because thought it was probably just that it had been ligated at the time of his prior left upper lobectomy. And you can see that on his perfusion scan, there's virtually no perfusion to the left lung. The mean was, as you can see here, like 6% total. And then they just did a follow-up CT with contrast. Not that this was really necessary, but as you can see, there's no flow to that left inferior pulmonary vein. So this was presumably iatrogenic, ligation of the left pulmonary vein. And talking to the surgeon, our surgeon here, because this has been in an outside hospital, they always obviously try and assess the anatomy pre-op. Certainly, we know that under incorporation of the left pulmonary veins resulting in one pulmonary vein on that side is not uncommon. And so presumably they just ligated the whole thing when they did the thoracotomy and the left upper lobectomy. But it took him almost 20 years to present.
Can you show the left main PA? Is there there is an attenuation difference? Because usually there should be a slight attenuation difference.
Very good point. Yeah, it's like
because it's just decreased flow from the increased pressures, and it does. You can see it is definitely darker. Okay, cool.
That's a very good point. Yeah, it's kind of like
So I'm surprised there's that much opacification at all of that left pulmonary artery.
By the increased pressure downstream, yeah. And you can see all the collaterals too. So he's got a lot of transpleural collaterals. Oh. Sorry, say that again, David. You're breaking up.
I'm just wondering where that blood is going. It must be, it's got all those tiny little dots that are lighting up in that left hilum. Are those little veins or venules or something?
Well, what I don't understand in cases like this, and this is a question I wanted to pose, because obviously if you have two pulmonary veins and you ligate one, oftentimes they develop veno-venous collaterals like we've seen. In this case, though, a lot of these collaterals we see are hypertrophied systemic arteries. And you almost wonder if they start to develop some sort of retrograde flow into the pulmonary artery via the systemic arteries. And I don't know, because this is clearly a big inferior phrenic artery, and all of these transpleural collaterals. And I don't understand the physiology in a case like this, but your point's very good, David. It's like, where is this blood going? And I don't know which direction this goes. you know, because I don't see collateral veins that have developed, you know, transpleural. Maybe there are some small
There's
ones,
going to be
but
some peripheral. There's
I'm
going to
not
be
sure.
some peripheral drainage,
Yeah.
but not much. I mean, not compared to the vein. But you know, it's a good point. I know which way the blood flows.
Yeah. But anyway, it's just like, you know, even on a non-contrast study, you can, you know, if you see what looks like asymmetric edema, especially if it looks chronic, always look at the pulmonary veins.
Yeah, so you do have.
And I was going to say,
there's a lot of small vessels in that lung base. Probably getting their blood from somewhere not legitimate.
Yeah, and many of these are systemic collaterals too, because you can see there's enlarged intercostal arteries on this side, and like I showed, the inferior phrenic artery, and
yeah.
But I was going to say they are treating him. I'll show you just an excerpt from the pulmonary hypertension note that they are treating him like basically some kind of a pulmonary veno-occlusive disease, but they're trying sildenafil, closely monitoring him to make sure that it's not going to affect things too much. But okay, Jeff, I'll stop there.
Okay, thanks. I have a companion case I'll show later, sort of a companion case, I guess, but we can talk about that perfusion. Okay, who'd like to go next?
I can go.
All right. Where are you? There you are.
So use the right screen here. Oops, disappeared. All right. This is just, you know, I've seen a couple of these now, then they're not the most common. So this is a patient with a, it's actually more like an L transposition with kind of, but there's kind of this pulmonary atresia, but, and you can see this large VSD, but the interesting thing here, so that here's the left atrium back here in its normal position. And the left atrium actually drains into the right ventricle. So that's the primary drainage point, presumably through a tricuspid valve. And that gives rise to a aorta. And then the right ventricle, so you can see this is the right ventricle. Here's the SVC partially draining, what would be draining into it if it wasn't, didn't have the fontan, the lateral tunnel fontan. So here's the IVC. Crisscrosses and actually drains into the left ventricle. So this is a crisscross heart, where the basically left atrium drains into the right ventricle and right atrium drains into the left ventricle. And this patient also has a double outlet. Yeah, I'll just show the 40 flow. I think it just better shows it. So here's the that's the VSD, large VSD. Here's the right atrial blood going into the left ventricle. Here is the left atrial blood going into the right ventricle. And then here is the double outlet where you have big VSD, communicating VSD in both ventricles pumping into the aorta. No real pulmonary artery. The pulmonary circulation is supplied by the fontan. So just I don't know, I like crisscross hearts. You don't see them very often. This is a case we had yesterday, and there's two cool things about this. One is the right arch with mirror, what I thought was initially going to be mirror image branching, because I didn't see a kind of retro esophageal aberrant subclavian, but there was one. It actually, interestingly, was one here, but it got occluded. I don't know, I'm guessing probably congenitally occluded. And no, you can see maybe a string of thing here that is actually part of what would have been the vessel, but then the subclavian over here reconstitutes. So here's kind of a string of the vessel back here, reconstitutes via an aberrant subclavian. I mean, not the aberrant, via the left vertebral. So, but that's not even, that's just the part of it. So they asked me, someone said to me like, what do you think this mass is? And, I looked at it, it's well-rounded. There's more kind of, to me, it looks like slow pressure erosion of the vertebral bodies, kind of slow pressure erosion here. Now, it didn't look too aggressive, but the weird thing about it was that it was kind of going into two neural foramina. Now, most neurogenic tumors go into a single neural foramina. Of course, it could be a meningocele, and those can go to multiple neural foraminas, but this isn't fluid, this is soft tissue. So we were debating, is this going to be, some people thought it was going to be an aggressive malignancy. I was still voting some kind of neurogenic tumor, but they biopsied it. And does anyone want to guess what this would be? What this was? Wasn't even on my differential. This was tuberculosis. So, yeah, that's
Wow.
what I said. So they biopsied it and they got TB. And I don't even understand it for TB because I would think, I don't know. I would think TB would be a little bit more destructive, but I guess not.
Hell, yep. That violates Caney's law. I thought we were going with two congenital things here.
No. Here's some few. I don't know. I still don't believe it. But it is. I mean, it is. They biopsied it and they got all necrotic tissue and this, and then they sent it. They saw bugs and they sent it for AFB and it was all positive. So, anyways, that cool case.
So,
and then,
so not to get too far in the weeds, but I'm Arch. Hey, Seth.
Yeah,
I would let Arch a right arch with an isolated left subclavian artery.
Yeah,
with a comeral diverticulum.
So
is that?
yeah,
I'm just curious
sure.
if that's the nomenclature that others would use.
Yeah, it is. It is isolated.
Yeah.
I wasn't sure because I saw this piece that looked like a occluded vessel extending. I can kind of follow it towards this little area here.
Yeah, no,
but it is
that's a good observation because that's the part that regresses, that results in the isolation, from my understanding. So it's kind of cool. It's kind of like when you see the ligamentum arteriosum.
So here, right. So I saw this part regressed, and I just said, but you're right. It is actually, that's better terminology. It is isolated. Thank you for that. This was a cute case. Let me do this only because this patient was relatively asymptomatic, and so this is a patient who has left-sided. I'm not even sure if it's a left-sided SVC. I'm assuming they called it a left SVC. I'm still not sure if it's just part of coronary drainage or not, because you can see other coronary veins draining into it, but it's probably a left-sided SVC. It's just hard to tell without the full chest. And it comes underneath and is the coronary sinus, basically. And then this drains into the left atrium. But the interesting thing about this is that the Thebesian valve was stenotic. So you can see there's really no good drainage point for this into the right atrium, because normally, we with most of these, at least from my memory, there was still a kind of an open Thebesian valve, and you would get blood flowing from the, that's why it acts like an ASD, because you get blood flowing from the left atrium into the coronary sinus into the right atrium. But because this Thebesian valve is atretic, you're actually not getting that blood flow. The blood flow is actually going to go from the, in which it was going, was the higher pressure actually was the coronary sinus. And we showed this with 40 flow. I was trying to get the flow up, but the flow was actually going from the coronary sinus into the left atrium. So it was acting more like a right to left shunt, but a small right to left shunt. Not really physiologically significant. The QP, QS was like 0.9 or something. And the patient was asymptomatic and the blood oxygenation saturation was pretty much normal. But because, we're in today's society, they went in and still fixed this thing. But I just don't, I'm sure there is a classification for one with an atretic kind of drainage into the right atrium. I just don't. Yeah.
What did they do for it?
They actually put a covered stent, which to me doesn't make any sense, because then I don't even know where it drained to. So I think they might have opened this. I think they might have done something and poked a hole through this and dilated the valve here, because there was a little bit of drainage, and then they like you can see a little bit draining in. So I think they went in, they kind of dilated this and then put a covered stent over.
Because
allow.
there are cases of there are cases of osteoatresia of the coronary sinus with that little SVT that drains north, and then you ligate that that vessel, and then you end up with a myocardial infarct from venous obstruction.
Yeah.
From like the middle cardiac vein. And this is kind of like a form of that, I guess, but it's just draining into the left atrium, which is really interesting.
Yeah. So I showed one many years ago of osteoatresia or kind of Thebesian atresia where the left side SVC was massive. And we actually did an MRI and showed that it was draining superiorly. But we didn't see that on at least the pre-op 40 flow study. It was still draining south. So just an interesting case, a little bit of a twist. And then lastly, let me show these, and then let me pull up, sorry. See if it'll let me open up all these. Anyways, I'll skip the chest x-ray. This chest x-ray is very pretty, but yeah, whatever. Okay, so let's see where I am here. Oop, that zoomed in. Anyways, I think we all know what this is going to be, and this isn't the best image to demonstrate it. Sorry, I always hate when I have to do this. Let me just pull up the one with the thinnest slices. So this is a patient with PLCH. I think we all can look at this and say it's PLCH. The interesting thing was that it was, when they showed this to me, I said, yeah, no, it's definitely PLCH. The interesting thing is she was a minimal smoker, not like she smoked like a cigarette or two a day. She did vape marijuana, but the interesting thing to me was that a lot of this, the distribution isn't entirely typical for normal inhalational PLCH. There's a lot of lower lobe involvement, and I said, she's a young person, and they did biopsy this for some reason. It was PLCH. She's a young person. She smokes very minimally. You can see she's quite osteopenic. She's had a lot of health issues that are kind of for unknown reasons, and I said, hey, this could be something systemic, like a systemic histiocytosis. Again, it's just a lot of lower lobe involvement. So she had this kind of chronic rash on her legs. This is her legs. And they biopsied this, and this was PLCH or Langerhans cell histiocytosis as well. So I still think they're working her up to see if it's a malignant histiocytosis or some other systemic histiocytosis. But I think I've shown a couple of cases now over the years, maybe 3 or 4, where people, too, with malignancies that have, because it's, this is a bloodborne process instead of an inhalational process. So the 2 people that I've shown that were definitely had malignant histiocytosis because it's, most blood goes to the lower lobes, even though its inhalation still goes to the lower lobes due to the lymphatic drainage, they say, and the ability to clear the particles. It tends to be upper lobe with smoking, but the ones that are bloodborne from some malignancy truly are lower lobe. So yeah, just a nice example of that.
No neurologic things, nothing to suggest she's got brain involvement.
They're working her up, like literally, but she had some brain issues, had some enhancement in the brain. Initially, she was on the outside, she was called metastatic disease.
Okay.
So there, and she had some areas of enhancement in her brain that was called metastatic disease, and she came here and we're like, no, this is PLCH.
Well, it's not PLCH, it's LCH.
Sorry, LCH, you're right, LCH.
Right. And with that skin involvement, this is almost certainly what you're thinking. This is really not the smoking related LCH. And
they're like, oh, stop smoking, and I was like, no, that's not.
Yeah, how old is she?
24.
Okay, that's perfect. So, you know, the childhood things are, you know, Hand-Schuller-Christian and letter seaweed. This would be more that Hand-Schuller-Christian variety
What?
of a
I
teenager.
don't remember the difference.
Yeah. Well, they're just different names for really the malignant kind of histiocytosis.
Yeah. She's a young girl, 22, 24, very sick.
Yeah, that fits.
Yeah. So anyways, those are my cases.
Okay, those were awesome. Okay, let's see, Brian or Peter.
I have a few, Jeff.
All right.
This was a case that came up today. Just a good case of calcified pulmonary nodules. And so it's a female patient. She's 69, and we don't really have any. We have several prior scans, but we don't really have any relevant clinical history. So the first scan on the left is the oldest scan, and it's from 2007. The one in the middle is from 2017, and then the one on the right is a calcium score from today. And so you can see all these calcified nodules throughout the lungs. There's a big kind of popcorn calcification here, medial subcarinal, large lymph node. And they have like a benign appearance. They're round, and they have central bullseye calcification or popcorn calcification. And it's just interesting to observe it how it evolved over the years. So you can see, for example, here, there's coalescence of these nodules. And so it looks like they've grown, but it's most likely just coalescence. And then this is
not much in the upper lobes here.
I think I think it's kind of diffuse everywhere. It's diffuse. And this is today's, and you can see this cavitation that's now formed here, and there's a broncholith here. So and then of course this was biopsied a few years ago, just because they thought they interpreted it as growing, which they kind of look like they're growing, these nodules. They just wanted to make sure there's a malignancy. And as you would expect, this came back as granulomas. So this is just most likely here a broncholith that has eroded into the airway. And we don't really know what they're from, but just we thought this is probably just histoplasmosis, and from a really high inoculum, like a she has no history of, it doesn't look like disseminated or anything. She doesn't have history of immunodeficiency, but probably she just had some kind of really high inoculum of a.
Has anyone ever seen disseminated endemic fungus with nodules that big, though?
No, I was thinking amyloid the first second you showed.
I
was like, these look like classic amyloid nodules, even though I've not seen.
And with the big calcified lymph nodes too.
Yeah, but came back as granulomas.
So,
And no, did they do a fungal stain? I mean, or anything to try to see if they saw any bugs in it?
Yeah, they I don't know if they did the stain, but they cultured it and they weren't able to grow anything out of it.
Very perilymphatic too. You can see the major fissure there. There's like studying of it.
I think they're kind of yeah. There's some of them are on the fissure. But so isn't there, in my opinion, I thought there was a distinction between a disseminated where it gets into the bloodstream versus inhalation of a really high. So these could have all potentially been inhaled, or am I wrong? So they could have just inhaled like a.
So the mechanism is you inhale the spores and it turns into a yeast,
right,
which quickly becomes bloodborne but gets stopped rather abruptly by the immune system. That's why you see the splenic calcifications frequently with disseminated, with histo in general. But the cases I've seen of high inoculums, which have been usually, I've seen them in someone who cleaned a chicken coop, and people in caves where there's bats, so small
Splunkers.
They
Splunkers,
get,
definitely.
tiny little nodule. And
Yeah.
one of these I could buy being like a histoplasmoma, but this is like histoplasmomatosis. And I mean, if that's what it is, it's really cool. But considering we see histo pretty much every other scan, this is crazy. And
What
could this
about the
be
spleen?
granulomatous inflammation around something? The other thing I was thinking is this like benign metastasizing leiomyoma, or
Yeah, that was included in the pulmonologist. Obviously,
It does have splenic calcification, guys.
yeah,
The spleen is calcified.
spleen has
I think that throws it back to histo.
yeah. Well, maybe she has some just weird
But-
immune,
yeah.
like one of these subtle deficiencies that these are just all histoplasmomas.
Sorry, I dropped off for a moment, but you're saying this is all just attributable to histo? Is that what the current thought is?
We don't know that, but I just wanted to see what you guys thought.
Because there's the
World, Peter,
Yes.
where's she from?
Oh, where is she from? I looked back in the chart and I wasn't able to find anything relevant really.
because there's the entity of like hyalinizing granulomas or hyalinizing granulomatosis or
yeah, that's exactly what it says on the pathology. It was hyalinized granulomas was on the pathology report.
But again, that doesn't explain why.
No.
What about sarcoid or pneumoconiosis?
No.
I haven't. Yeah, I mean, to me, this is
the spleen calcification, guys. It doesn't have the messy look of sarcoid. There's not a lot of scarring. I was wondering, first of all, when you were talking about coalescence, whether this could be silicosis. But these are very well-defined nodules. I have a case of histo. I thought I showed at this conference a couple of years ago that has these huge lesions. I mean, they're even bigger than these, and just multiple all over the place. A ton of big calcified histo nodules, and that was proved histo. I'll try to mobilize that case for next time.
And the other thing is they've continued to inflammation, continuing inflammation over the years. And then the amount of calcium has also increased in each of these nodules just over the course. But okay. I will show another one. This is we'll start at the axials. This is I think middle-aged patient, but he came in about a week ago with sudden onset chest pain, and there was concern for dissection, so he got this CTA, chest, abdomen, pelvis, and the general surgeon, the thoracic surgeons looked at it, and they saw this, which is the most obvious abnormality on the scan, this flap here. So they thought this might be a type B, and they for some reason they thought it was a chronic looking type B dissection, but there are some other more subtle findings on here which can suggest a different diagnosis. So this density here, it has Hounsfield units in the 50s. And then take a look at going down, take a look at the ascending aorta. There's this abnormality. So this is a non-gated study, but we'll take another look at this abnormality and looks better on the coronal scan. And then the other thing to note here is the soft tissue that's encasing the pulmonary vasculature bilaterally. And so here's the coronal. So here's the obvious flap there. And you go to this image, for example, here, you can see I didn't like this little contour abnormality here. And you can see how big of a caliber change all of a sudden there is in the aorta immediately after that. And then you can also appreciate the soft tissue that's encasing all the pulmonary. So this was another intimal tear here in the ascending aorta. and then there's hemorrhage into the interstitial sheath, which is shared with the pulmonary arteries. So they operated and they confirmed there's another tear here in the ascending aorta. And most likely, if they continued, I've seen one or two other cases with these little tears that look limited at this point, but they can easily evolve into a real dissection if not operated on. So this patient had a ascending repair also. It was done a few days later. Okay, show this one. Maybe I can get some opinions on it because we weren't completely sure about this case. But this patient is a middle-aged lady. She's in her early 50s, and the only history she has is asthma. She did have COVID positive test in late July, and she didn't require hospitalization. I think she was just treated from home. In her x-rays, she had some x-rays from that time, and she didn't really have much. X-rays just looked normal, so not much in the way of really bad acute lung injury secondary to COVID. And she's just been kind of coughing, short of breath since then, but hasn't required intubation. So this is her CT. So there's all these scattered nodules, and you can see some of them, at least one or two, several of them actually have little central lucencies or cavitations, and they're very diffuse. So we didn't really come down hard on anything, but I know you guys have talked about meningothelial like nodules. I wanted to see what you thought about this.
I think
the other thing I was
going to say, Peter, I think it's a great example of meningotheliomatosis.
Okay.
She's the right demographic. They have the right appearance. I don't think her cough is at all related to that. I don't know if whoever else is on.
Yeah.
But
I thought those are usually more ground glass than.
no,
than
I mean,
cystic.
they're small, they're smudgy, but they're not like hazy RB nodules, and they often have a central lucency or umbilication, and they seem to be slightly lower zone predominant as yours are. But
yeah, I don't feel too confident with that because that diagnosis, but I know you guys have. I noticed you guys have talked about them. So, but okay, so.
no, anybody else?
What about cystic metastases? Because it looks like it's lower lobe predominant.
Yeah, it is. Yeah, I guess. Yeah, there's maybe a little bit more in the lower lobes. And the other thing I thought about is some kind of secondary follicular bronchiolitis from her asthma.
Yeah, but they're not all central lobular, so.
Right.
I really like meningothelial-like nodules. I think that's likely what it is. I mean, it would be reasonable to get a follow-up in 3-6 months, and if they're stable. We see them like once or twice a year, and if you go back, if you have old imaging, you can often see them for years. And yeah, I think after we biopsied the first one, we stopped biopsying them. It's been better described in the literature.
Yeah.
That's a nice example, assuming that's what it is.
Yeah. Okay. I'll show one other quick one, just kind of.
With that person's long history, she probably has some old imaging to compare. And as Jeff said, if it's over years, I think that nails the diagnosis.
Yeah. The only thing we had is some X-rays, radiographs from months ago, but we didn't have CTs. She might have other imaging elsewhere. This is just going to be one of those quick ones, but I don't remember if this patient is from a week or two ago, but I don't remember if it was for chest pain or what started first, chest pain or abdominal pain, but she had both. And you can see this is for PE, and you can obviously see the pulmonary emboli, and then there's an abnormality here in the left atrium. There's a filling defect, and you can kind of see it coming across right there also. So this patient has a pulmonary embolism probably elevated his QP, elevated his right heart pressures, and that opened up his or her PFO. And she had imaging of the brain, but that was luckily normal. But unfortunately, if you look, and there's an abdominal scan here. On the abdominal scan, you get a better appreciation of this clot here across the septum, and then her. You look at her SMA is completely occluded here, and just here's a nice. Nice fluoral angiogram here. When they intervene on their SMA, you can see it completely clotted off. So a paradoxical embolism through a PFO.
Wow.
That's a good one. Nice aorta cases today. Okay.
All right,
Thanks, Peter.
guys. All I have.
Brian, you got anything this week?
Sure, I can do one. Hi, can you guys see my screen okay?
Yeah, we can.
Excellent. So this is a companion case to a case that Seth showed a few weeks ago. Seth showed a thymoma that looked like it kind of exploded into the left chest without clear pleural-based metastases. And this is someone with a liposarcoma who you can see here. This is actually a recurrence or a metastasis in the contralateral lower extremity. This is a CT showing recurrence from the primary resection bed of a liposarcoma. And then there's this small pulmonary nodule here, which had popped up over serial imaging, and you can see there's a faint amount of tracer uptake on an FDG PET. So they didn't believe that it was a metastasis, so they wanted a biopsy, and it was a tricky biopsy. One of my partners did it, and you can see not helped by the fact that there's a right mainstem intubation, and this actually came back as negative for malignancy, but within about 10 months. The patient came back with this rapidly enlarging left pleural base mass. This popped up within maybe 5 months after imaging, after the biopsy, and then slowly got bigger and bigger. And you can see it's somewhat low density, kind of similar texture to the original liposarc. And this was recently biopsied, and it came back as metastatic liposarcoma. So it reminded me because Seth showed one a few weeks ago of a thymoma, which was biopsied, and it was right over here. And then after the biopsy, she came back and there was tumor kind of all in this area. And I was wondering if some of that could have been from the biopsy tract. Typically when we try and biopsy thymomas, we try and stick within the mediastinal fat. That person, if I recall, was pretty thin, and it was mostly down here. But anyway, just a good example of a liposarcoma biopsy tract seeding. And a good example of why, if you're going to biopsy something like a sarcoma or other malignancy like that, to consult with your thoracic surgeon in case they're going to consider doing a metastectomy. That's it.
So is the presumption that was just a sampling error with the smaller nodule?
Yeah. I mean, you can see here like all this atelectasis that developed because here's the ETT. I don't know why they had to intubate him, but here's the ETT mostly in the right mainstem bronchus, and so all this atelectasis develops. So you can't even see the nodule, and then you have this tough window to get through. Yeah.
Okay. Nice. Okay. David, do you have any cases?
Not this week, sorry.
All right. No, that's all right. I've got some I can show. All right. Let's see. Okay. You see okay, yeah. So this case was sent to me by a friend of mine in Massachusetts, and I've sent it to a couple of you, but I've seen what anyone else has seen this. So I don't have any history, but patient has a funny vascular anomaly. So I'll start at the bottom. So here's the IVC, and you can see it's a little more lateral than usual. Hepatic veins drain into it. It comes up here, and this is, unfortunately, I only have video, but I can't window, but it clearly comes up and looks like it passes through the lung. And then it joins into the right atrium, sort of up high, at the same level that the SVC joins in. you can follow this down. And even the SVC looks like it's in a funny location. It's unclear if it's actually in the mediastinum or not. And then there's an azygous fissure with the azygous vein coming into it. So I've never seen this before, and the only thing I think, to me, this looks like is a sinus venosus anomaly, where the two cavae sort of fuse they fuse to the right atrium at a single point, as opposed to where the inferior vena cava usually, the sinus venosus forms the posterior wall of the atrium. Because you'll notice the right atrium looks otherwise pretty normal. There's the coronary sinus, there's the appendage there, but I think it's just an anomalous insertion of the vena cava. I don't know, has anyone ever seen something like this?
So Jeff, there isn't an IVC in the normal location here, is there?
No, that's the whole point. Is it's the suprahepatic portion is abnormal, right, and it's inserting really high into the right atrium where the SVC joins in.
Wow.
What about below the liver? What does the IVC look like there?
Let's see. I think this is, yeah, it's normal there. This was purely incidental finding, but it's just, you know, I went back to my files and I don't have any. I looked at the inferior type sinus venosus ASDs, but we don't really have one there. There's no anomalous drainage. It's like when the sinus venosus fuses with the primitive atrium, you get sort of the separate locations of the IVC and the SVC, but in this case, it's just a really high insertion. I don't know. It was kind of crazy.
This is weird. I've seen a lot of, well, I've seen a few inferior sinus venosus, and I've never seen, I have no idea what this is. I was Googling for like a while trying to figure out.
Yeah, Howard sent one little case report of it, of like a low SVC insertion, but it looks like.
But it was a low SVC insertion. It wasn't a lateralized, and this is going into the lung. It's just weird.
Yeah. But it's not a scimitar, and it doesn't look like there's no anomalous venous drainage from what I can tell, and the airways look, what I can see of them, look pretty normal. So I don't know. It's a curiosity.
And it's not like any variant of an azygous continuation of the IVC, because as you pointed out, it's the entire IVC. There's no separate hepatic portion.
Yeah. Anyway, I just wanted to show that one because for those of you who didn't get a chance to see it, it's kind of cool. I don't have the DICOM, so I can't do a recon on it, but you can imagine what it looks like. Well, I also found this case, Peter. This is an old case report. You can see a really bad one where they took a picture of the film on the view box. But this is histoplasmosis, and they just show some large nodules in this patient. But I'm sure there's better case reports than this one. But they thought it was melanoma, mets, and biopsy, and it was all histo.
Oh, interesting. And then these are. We can't tell if these are calcified or not. Or we
can't tell a thing. They sent these, this is old school stuff here. Probably even PHI on here, but I can't, it doesn't look like, maybe they cropped it. Anyway, okay, speaking of congenital stuff, I'll show this case. This was just a fun case that came in not too long ago. So this was a PE study. And you see the big fat azygous vein here. That should always be a red flag, something's not right. And you can see it crosses over there. And then the azygous and hemiazygous are both big. So that usually suggests there's either obstruction or something congenital going on. He does have a pacemaker in. And then you get down to the belly and you realize things aren't not how they ought to be. The liver's backwards. There's a bunch of spleens here on the right. The pancreas is sort of just right in the middle, doing all crazy stuff here. So this is a heterotaxy, so presumably bilateral left-sidedness with polysplenia. And because I know David's going to ask me, I'm going to go ahead and show the coronal of the lungs. And yes, there are two arterial bronchi. And so we have left pulmonary isomerism as well. Can show that there's two left lobes. There is a funny fissure here, but it's a bilobe right lung with a hyparterial bronchus on both sides. And this guy was, I want to say he was in his 50s, and this was unknown. So I don't know, but somehow you can make it through that many years. But usually this is an incidental finding. It is associated with as is continuation of the IVC, whereas bilateral right-sidedness is often associated with congenital heart disease and asplenia, so it presents at a much younger age. So that was just an interesting case. And then I have another vascular case, and this is relevant to the one I think one of you showed, maybe it was Travis. So this is a young guy, he's 20, and was referred to our pulmonary hypertension clinic. He doesn't have pulmonary hypertension, but he has this funny aneurysm of the left lower lobe pulmonary artery. And if we follow it down, we see that the pulmonary artery just sort of drops out. So we don't really have much perfusion to the left lower lobe. There's a little contrast getting through. You can see there's a smoke artifact in the inferior pulmonary vein. There are what look like old infarcts, and there's hypoperfusion down there. And then similar on the right, and if we come back up, you'll see there's these vessels here don't really have much contrast in them compared to their neighbors. And then the other finding that's kind of interesting, and this is where I think it was Travis, yeah, we're talking about these collaterals. There's these pretty large paraesophageal arteries, and there's a big juicy bronchial artery, and there's actually a bronchial artery aneurysm. I'll show you right here. Coming off this left bronchial artery. Let me just go slowly. Right there, you see that bronchial artery coming through. That's presumably going down to that left lower lobe, but has a little aneurysm. And he presented with some hemoptysis, and that's the reason that prompted this CT study. So 20 years old, had a normal echo, so it doesn't have CTEPH. So I raised the question, could this be like a Hughes-Stovin, Bechet disease with an in situ thrombus and aneurysms? Or is this just going to be a CTED where he has thrombus? No history of DVT from what I know, but they're going to send off some inflammatory markers and see him in clinic rather than a televisit. But I can show the rest of his lungs. But some scarring that to me looks reminiscent of old infarcts.
How old is he?
20. That's why I'm wondering about like a Hughes-Stovin or Bechet.
Yeah, because I didn't realize this, but that left main PA is smallish, and it gets they always told me, like, which I never knew before, that it's very uncommon to see CTEPH in young men. It's like just from prior DVT or PE that it's common in young women, but young men it's very, very uncommon, and you should always think of something like a vasculitis or something else, which I didn't know before.
Yeah, and his echo is normal, and he has no PE history, and he doesn't have the typical. And I've never seen an aneurysm like this with CTEPH. Have you? Or?
No.
Yeah, to me I've seen pulmonary aneurysms in Bechet and which I've seen like 2 of one and 1 of the other. And it's probably
Jeff, we've also seen this sort of thing in people who injects drugs and stuff like that and get infections and stuff like that. Any history of injection drug use?
Not that I know of. And yeah, we've seen some pseudoaneurysms, but not that I know of. But that's a good point. And clearly it's been a while because he has quite substantial collateral vessels there. He just has some big, juicy systemic arteries, which, unless we do, it's just not normal. You see these arteries here around the esophagus. And he's got a big inferior phrenic there. So, I don't know. It was kind of cool. But I'll let you know if I find out more. This was kind of a fun case. So this patient presented about 3 weeks ago or so with cough and was found to have COVID. And you can see he has a very abnormal radiograph. There's peripheral opacities, but on the lateral, which I think there's too much stuff around the hilum. I don't know if that was appreciated at the time there, but it's hard when you have all this stuff going on. So anyway, was presumably COVID, but it was commented that it was a little bit abnormal. So patient recovered from COVID and developed, still was short of breath and coughing. So they sent for just a routine outpatient CT. And this is her scan. I'll show you. It's kind of cool. She's, I think, in her 50s. She's got this patchy ground glossopathy, but she has these perilymphatic nodules and a nice peribronchovascular distribution. So she has that, and then she's got this mosaic attenuation. We did expiratory images, and because I typically do those when I didn't know any history other than that. So yeah, there's air trapping. And then what's really, really cool, something we don't see very often, is if we look at the bones, if I can find some. If you look in the bones, she's got these lucent areas that are narrow zones of transition. There's a couple more that are a little more conspicuous. You start seeing them in the spine, narrow zone of transition. So otherwise previously healthy, other than this COVID. So I think she has sarcoid, probably with bone involvement. And then at the bases, I should have shown that better. I think she's got some residual organizing pneumonia from her COVID. What a lot of this stuff is down here. But I mean, we don't biopsy necessarily all our sarcoids, but it looks like the few times I've seen sarcoid in the bones. And she does have lymphadenopathy, I should add as well. So I think she has the residue of her COVID, but she also has sarcoid with bone involvement. Would anybody disagree with that and the airway involvement?
So she'd never been treated for sarcoid, right? She wasn't on steroids.
No, it's unknown diagnosis. It's a presumed new diagnosis.
It's a lot of, I mean, I know what happens. It's just a lot of mosaicism for sarcoid, but I guess with bone, if it's so severe, she has bone involvement.
Right. Unless, and the other possibility is it's related to her COVID.
Yeah.
And she has some small airway involvement. She's only about 4 weeks out from her COVID diagnosis. But I think she had sarcoid at the time she presented too, because I think there was that lymphadenopathy. I think it's hard to see. And it's a little bit, not the peripheral stuff, but more nodular. Anyway, I thought that was kind of interesting. Let's see if I have time for one quick one. Yeah, this is kind of fun. David, again, you'll like this one. So this is a patient's radiograph. I can't remember the indication. It was a cough. But you'll notice, you look at the upper mediastinum, it looks funny. Trachea is sort of midline. You don't see an aorta very well on either side. I don't have a chest CT, but I did come across a neck CT. And you can see here, there's the aorta, and this is a nice example of a double aortic arch. The 4 vessels, the higher right arch, it's about the same size, maybe a little bit bigger than the left. And it just descends practically in the midline here. So that's why you don't really see it on the radiograph. These can be, I found in adults at least, because they're usually asymptomatic, these can be really hard to see because the arches probably themselves aren't that big. There's one there, I'm guessing, and the other one's somewhere here. But you don't see that mass effect on the trachea. I should point on the lateral, though. I think you can see a posterior indentation there, but it's pretty subtle there. It's not the best quality image either. But it's hard to see the descending aorta at all. You just really don't see much of that interface because it's tucked in towards the midline. But these are very rare, like 1 in 10,000 people, I think, is what's quoted for double aortic arch. So fun vascular stuff today.
Very cool. Thanks, guys.
Well, it's the top of the hour, guys. So thanks very much, and I'll talk to you next week.
Thanks. See you next week.
All right,
later.